Dr. Nita Sahani is a pediatric anesthesiologist at Mass Eye and Ear Hospital in Boston. She completed her anesthesia residency training at Mass General Hospital and did a pediatric anesthesia fellowship at Tufts Medical Center, Boston in 2013. During her tenure as a former division chief of pediatric anesthesia at MEE, she led an amazing and cohesive team of highly competent and empathetic pediatric anesthesiologists while fostering collaboration with surgeons, physicians, nurses. She worked diligently to ensure optimal care for most complex, vulnerable patients. Her commitment to high-quality care for the pediatric patients and passion for learning led her to complete a formal 2-year master's in healthcare quality and safety from Harvard University. She has spearheaded many quality initiatives within the department and leveraging her skills and leadership experience both within the department and across the institution. She is a subject matter expert for management of difficult airways during challenging airway procedures. Please welcome Dr. Sahani.
So good afternoon, everyone. I'm Nita Sahani. Like I was introduced, I'm a pediatric anesthesiologist at Massachusetts Eye and Ear Hospital in Boston. I would like to thank the HADS Foundation for inviting me to give this talk because the pediatric anesthesiologists at my institution have a special connection. We've had the privilege of taking care of Lucas Tuso Ribeiro on multiple occasions, and we have bonded with him and his family. Unfortunately, I could not attend in person, but hopefully next time. Next slide, please. That relationship was my disclosure. However, I have no financial disclosures. Next slide. Since this is the last presentation of the conference, I'm sure everyone is very familiar with the HAD syndrome. And I think the audience here is an expert in this subject matter. And so there will be some repetition on my end related to the context, but this is a bi-directional learning platform. So my objective here is that parents leave this auditorium today feeling empowered that we are here for your child and for your family, and that most of the times you may even know more about your child than what the literature has to offer or the information we find in the medical records. So please feel free to share as much as you can when you meet an anesthesiologist. Our encounter with your child is short, but it is very critical. So in this presentation today, I hope I can outline the salient features of the HAD syndrome and review the impact of every symptom that we encounter during the surgical procedure. I want to review the importance of a multidisciplinary approach and how a thorough preoperative evaluation process prior to the procedure is critical for conducting safe anesthesia for your child. I will provide basic knowledge and understanding of the techniques of anesthesia utilized for pediatric or adult patients with HAD syndrome. I want to educate and provide information on the anticipated risk and complications during a surgical encounter, and discuss and provide answers to parents on their concerns and alleviate their anxiety and fears. Next slide, please. As everyone knows by now that hypotonia, ataxia, and delayed development are the distinctive features of HAD syndrome caused by the mutation in the EBF3 gene on chromosome 10. Thanks to the groundbreaking research by the dedicated team at Baylor College of Medicine, Dr. Chow, Dr. Wangler, and Dr. Bellin, this rare neurodevelopmental condition has a name and it has been identified in 2016. But let me assure you that even prior to it being labeled as HAD syndrome, we anesthesiologists have been providing care to children with hypotonia and ataxia or children with delayed development. And we strive to make sure that we provide safe and great quality care to these kids. The HADS Foundation and its website is an excellent platform for families to connect and share their stories. And like I said, it is a two-way learning here. And I have learned so much from the great work done by this foundation. Your stories and life experiences teach us to pay attention and not to ignore even the slightest information that you provide to us on the day of the procedure. Because that one thing you might tell us that day might point to some diagnosis or modify our plan. Your website is a great resource for also promoting awareness and knowledge and to provide a better quality of life for the children who are affected by this condition. Next slide. So I've labeled the symptoms here in an alphabetical order, and not all children or every child with HAD syndrome will be affected with every symptom that is enlisted here. But I would say that most of these symptoms will help us cater to the needs of your child and also to modify the plan of anesthesia so that your child is safe at all times and they return back to their baseline or even feel better before they leave the hospital. So when it comes to ataxia, which is loss of coordination of movement or muscle control, we want to know what are your child's baseline functional capacities or capabilities. Where do they fit in their milestones when compared to a child of the same age or of the same weight? When they have autistic-like tendencies, if they lack, eye contact, if they have sensory processing problems, we want to assure that we are sensitive to our approach towards them. We are able to offer you services that will make their journey as pleasant as possible, and they do not leave feeling more scared or fearful and nervous to ever return back to us. Since children with any syndrome, frequently visit hospitals or they come for procedures very frequently, we like to develop a bond with them. We want to make sure that when we see them the next time or the next time, they are also equally excited to see us, and they are not fearful of us, or they are not shy of us. So we want to make that, we want to create that bond with them. Now, delayed development, it could be gross motor, it could be fine motor, it could be language or social. And again, we want to interact with your child, we want to engage with your child before we take them to the operating room, so that when they wake up in the recovery room, they're able to express themselves better and they can tell us how they feel, what they feel, so that we can, take care of their pain, they take care of their other, post-op complications or side effects. Now, when they have dysmorphic features or any other body abnormalities, it is very important for an anesthesiologist to have a face-to-face interaction with them, because we use gadgets like a mask for induction, or we have to place an intravenous line on your child. And all these features will help us decide the right size of the mask, the right size of the cannula for placing an IV, and we might have to prepare or keep more gadgets ready in the operating room so that we perform safe anesthesia during the procedure and even after. When they have failure to thrive, it is very important for us to know their current weight and the current feeding protocols or procedures at home, because some of them might have a feeding tube in place. They might be on some medications, and our medications and airway devices are all weight-based. So we like to see and know where they fit on the growth chart so that we can assess what will be their needs, going to sleep and as well as waking up. Now, I'm learning myself that children with HAD syndrome have high pain tolerance. The other syndrome or condition that we are aware of where children have high pain tolerance is trisomy 21 or Down syndrome. And because anesthesiologists have been taking care of children with trisomy 21 for decades, we are very cognizant of this, and we do not give them higher doses of anesthesia, higher doses of pain medications, because their pain tolerance is high. So knowing that HAD syndrome children also have high pain tolerance, this will prepare anesthesiologists to, again, cater, the medications according to the needs of the patient. Now, hypotonia is one of the biggest symptoms, or the most important symptom that will allow us to make sure that your child is safe during the anesthesia, for the procedure, and actually the post-op recovery. So we do go into a lot of details about hypotonia, because hypotonia not only affects the voluntary muscles, it also affects the involuntary muscles. And when I say involuntary muscles, it is functions like swallowing or bladder function or GI symptoms like constipation. And once we are aware of the severity of hypotonia, their motor function, we will make sure that we do everything to keep your child safe. If they've had aspiration issues because of hypotonia, because they have laryngeal muscle tone weakness, they have laryngomalacia or tracheomalacia, or they have laryngeal cleft, then these children are prone to aspiration. And when they aspirate the stomach contents into the lungs, they develop pneumonias. So we want to make sure that either when we are inducing anesthesia or when we are waking up your child after anesthesia, their stomach is empty, and we don't want those contents to come up and regurgitate into the lungs to further worsen their existing symptoms. So we will try and aspirate their stomach, empty it before we go to sleep or as when they wake up. We will provide anesthesia, which is short acting, so that their muscle tone returns back to normal. So these are very important. This is very important information that we want to hear from you, so that we can cater, the anesthesia to the needs of your child. Speech delay, mostly for us, it is important because we want your child to express, in their own words, how they are feeling, what they are feeling, or we want parents to advocate on their behalf. And we want to make sure that we are, again, taking great care of your child. Most of the urology symptoms don't really affect anesthesia, but then if there is any neurogenic bladder or there is severe constipation, we don't want your child to have retention of urine in the post-operative period, or we don't want their constipation to worsen because we gave them higher doses of opioids. So we would, discuss all this with you so that you can treat them with their usual medications before coming to the hospital. Next slide. It takes a village. I say that even for my own children. So it cannot be a one person's job or responsibility. It has to be a team approach. It has to be a multidisciplinary approach. And we all have to collaborate. By the time your child has come to us, you have already consulted a number of specialists. And in order for them to provide answers to you, they need to perform tests or procedures. And that is where we come in. And hence, we love to collaborate with the gastroenterologist, the neurologist, the surgeon, and gather as much information about your child before they even come to the operating room on the day of the procedure. We even have social workers who get involved. We consult our local pulmonologist or neurologist if you're from out of state or if you are from a different country, because we know the systems are different. We may not be able to reach your particular neurologist or pulmonologist and get all the information from them. But we do take recommendations from resources that are available within our institution or our neighboring institutions so that we are fully prepared to take care of your child. Next slide. Now, these are some of the procedures that are usually performed on any child with hypotonia or developmental delay. So when probably your child is born and still doesn't have a diagnosis, you might present to us for some diagnostic procedures like imaging, MRI or CT scan, bronchoscopy because they've had some respiratory symptoms or they have some airway problems. Or like I said, if they have recurrent pneumonias from aspiration, then they need a bronchoscopy or a lavage. Endoscopy for upper GI or lower GI symptoms. And then they might need therapeutic procedure or the definitive procedure for, say, a lazy eye or strabismus when they have poor vision, or a bronchial lavage to diagnose their and treat their pneumonias, or ENT procedures to repair their cleft lip or place stents to maintain their airway open. Feeding tubes for patients with feeding problems or failure to thrive, orthopedic procedures for either ataxia or for hypotonia, and the urology procedures that I had mentioned before, probably for undescended testes or for reflux. And in all of these, now imaging actually is one of the most earliest procedures that your child might have to undergo. And because this procedure is not performed in the main operating room area, this procedure is performed in an off-site location in the radiology department, which is where this no surgeon is present. It's only the anesthesiologist and the radiology technicians. So this is actually a place where anesthesiologists like to be the most prepared. Uh, Off-site location anesthesia for pediatric patients is by far the most challenging and the most scary encounter for everyone. So when we know of a child who has symptoms which point towards a syndrome, we are extra cautious, more vigilant. We try to bring in all the resources that we need to that offsite location so that if we were to run into any problems, we are not scrambling, we are very well prepared. And hence, I encourage parents, I encourage surgeons to inform us about any patient with any abnormal symptoms or any different body or facial abnormalities to consult us so that we are familiar with their needs and our needs, and we are very well prepared. Next slide, please. Now, though most of the institutions will have an anesthesia consultation process in place, you might not always end up in a tertiary hospital or a children's hospital. You might end up in a community hospital, or you might end up in an emergency situation in any place where you're not familiar with the team. So always request for an anesthesia consultation for your child if your surgeon or provider hasn't mentioned to you yet, or it's not a part of the protocol. Some institutions will also have a pre-op evaluation center in place, whereas others will have a phone or a virtual consultation system. Now, your stories are powerful, your voice is important. So please advocate for your child, advocate for their safe care, and demand or request an anesthesia consultation, because you don't like surprises and we don't like surprises. We all rather be in this together and we form a plan before we take care of your child. So, and also request for a pediatric anesthesiologist to take care of your child, because that extra training and experience really goes a long way. Now, when we receive an anesthesia consultation, we do a thorough pre-op assessment of your child. We really dive deep into the entire medical history and the examination. We want to know everything about your child, starting from any allergies that they could have had, seasonal allergies, food allergies, or allergies to latex, because we want to avoid bringing your child in contact with any allergens that can confuse the picture when your child presents with any problem. We want to eliminate any source of gray area here. We want really clear-cut signs so that we are able to provide only what is necessary and keep it really simple and straightforward. We would like to know any anesthesia-related complications in your child. If you've already visited another hospital before, if your child has already received anesthesia in another hospital, we would like to obtain the anesthesia records from that hospital. If it is possible for you to bring them, that's excellent. But now we have resources. Fortunately, the system is becoming electronic. Most of the bigger institutions, tertiary hospitals, have the same electronic system in place. And so we are able to access medical records without having to call offices now. But there are many places where the system is still not in place. And in that case, we have to make these phone calls. And hence, we need that prior notice from the surgeon's office that we have scheduled this child for a procedure 2 weeks from now. And they inform us the very same day you have visited them in the clinic, because it takes us at least a couple weeks to get all the information we need from all the specialists that you visited during the lifetime of your child. to access those records, to go through them, and then to format a plan for your child. If any of your family members have had any problems with anesthesia in the past, and this is not related to HAD syndrome because your child might be the only one with HAD syndrome in the family, but there are other anesthesia related genetic problems, and we would like to know those because, God forbid, we don't want your child to have HAD syndrome but also have another condition which is also lingering somewhere in the family and you are not being made aware of it. So it is always good to keep your mind open, ask questions from your family members before you visit us, whether they've heard of any, major complications in the family related to anesthesia. We like to know the birth history of your child because that is very critical in knowing how your child will behave with us during the anesthesia induction and in the post-op recovery period. If your child was born with any respiratory complications, like they required supplemental oxygen in the neonatal unit, or they were placed in the ICU and they required a CPAP, a nasal cannula with high flow, I'm so sorry, my phone just rang. High flow nasal cannula for keeping the oxygen levels in the normal range, or if they were intubated and were on a ventilator. All this information will help us decide what we should do for them when they are being induced for anesthesia or when they are waking up. We might have to involve a respiratory therapist. We might have to have the high flow device available. We might have to have the CPAP machine available. So, and if your child has developed chronic lung disease during their initial years of life, then, and if they are on nebulizers or any form of treatment at home, we would prefer that we offer that treatment just before we induce anesthesia so their lungs are optimized and they don't have bronchospasm or laryngospasm as they are going to sleep under with anesthesia or when they are waking up in the recovery room. Not only do we focus on the symptoms which are related to the HAD syndrome, but we also review all the other systems like any problems with the heart, any problems with the liver, kidney, any thyroid problems, any other neurological symptoms. Has your child ever had seizures or are there any bleeding or clotting disorders? We also like to know the medications. What medications are your children on at home? Are there on any seizure medications? Are there on any medications for ADHD or autism or even for probably stimulating the appetite? And not all these medications might change our plan, but sometimes your child might require a higher dose of anesthetic or a lower dose of the anesthesia, depending on what medications they take at home. So, and we will also guide you whether you should give those medications the morning of the procedure, because, most of the times we want your children to be fasting for at least 8 hours before the procedure, and which I will tell you more in detail. We also like to review the imaging results, any lab results that your child might have had till they, come for this encounter. So if we have access to them electronically, great. If not, and if you have paper copies or, electronic copies of them, please share them with us. And then we also reach out to, your specialist for clearance. If your neurologist is not comfortable that your child goes through a very elective, say, a gastrointestinal procedure at a particular time because their seizures are still not better controlled, or they need to focus more on the hypotonia, or the pulmonologist is not sure whether your child's pneumonia is completely treated and, they still have some lingering symptoms. That is not a good time for, them to have another elective procedure because they will definitely have anesthesia related respiratory complications if they haven't recovered from any of their present illnesses. And then this phone consultation also gives us a chance to give you instructions on what to feed your child, when to feed your child, when to stop feeding your child, so that when they come to us for the procedure, they have been adequately fasted. Most of the times we offer clear liquids, which is apple juice, cranberry juice, water to your children until 2 hours before the procedure. But if your child is on thickened fluids, or if your child is has a G tube or a JG tube, then these instructions will be different. Then you cannot give clear liquids to your child. You might have to give something to the G tube and stop at a certain time, or you might have to fast your child for 6 extra hours, because giving thickened 2 hours before would result in aspiration. Then we are trying to induce anesthesia. Next slide, please. Again, the pre-op evaluation does not end with just that phone call or that in-person visit 2 weeks prior to the surgery. It continues until the time we go into the operating room. So now you're in the operating room, you're in the pre-operative area. You're going to meet the surgeon, you're going to meet the anesthesiologist, you will meet the nurse from the operating room. The goal from each one of us is that we psychologically prepare the child and the parent before we take the child to the operating room. We want to assess the current functional status. Has anything changed in the interim period between the time we spoke to you over the phone to the time you present today for the procedure? Did they develop a cold, cough, fever in this 2 or 3 weeks of time? Because again, that will totally change how we will proceed. We might even want to cancel the procedure, because we don't want to increase the perioperative risk of your child if they have not fully recovered from any of the respiratory illnesses. We want to make sure that the NPO instructions that were given to you were followed and your child is appropriately fasting, so that we can proceed. And if the surgeon is delayed for some reason, if the surgeon is operating on a child and is taking much longer than anticipated, and your child is next to follow, and your child has now been fasting in the preoperative area for hours, it gives us a chance to now give your child some, clear liquids or some popsicle, depending on, what was the time offered by the surgeon. We like to discuss intravenous access concerns. If your child has been to the hospital several times, if they were in the neonatal ICU, they have had multiple IVs in the past, probably it might be a challenge now for the anesthesiologist to place an IV in the operating room. So they will discuss what are the other alternative methods of accessing the IV. If your child is anxious, nervous, we will offer preoperative anxiolytic, and these might be oral midazolam, oral Precedex, or it might be an intramuscular medicine like ketamine or dexmedetomidine. All this is so that your child does not, or so that your child does not have any PTSD or does not go back with a bad, experience in the hospital and is refusing to come back the next time. We will discuss a full anesthesia plan with you about how we will induce your child, how we will manage your child during the surgery, and what happens and what to expect in the recovery room. It will be a collaborative effort between the surgeon, the anesthesiologist, and the parent to decide where the child will go after the surgery. Will the child recover completely and will go home, or will the child need some extra monitoring or extra care and will have to be an inpatient in the hospital? Or the child's care might be escalated and might have to go to the ICU. So all this discussion occurs even before we go into the operating room. Next slide, please. Now, like I mentioned, that the psychological preparation of the child and parent is really important. And we realize that it is an overwhelming experience for the child and the parent to plan a procedure, to organize a trip to the hospital, sometimes travel between states for specialized care or travel between countries. And we are fortunate here in the United States that most of the hospitals now have this special service called Child Life Specialist. These are trained child psychologists, and they are an invaluable resource. They play an important role in the journey of your child in the hospital. They provide virtual or in-person tours to families to familiarize them to the hospital setting and the entire process. They spend time with your child and the parent on the day of the procedure. and assist them in settling in after the registration process is complete. And now, based on the age of your child and the level of anxiety or concerns, they use appropriate distraction techniques like toys and games and arts and crafts, iPads to play video games or watch movies and sing songs. All this to alleviate anxiety and introduce your child to, say, the mask, which is going to be used for making your child go to sleep, or the entire IV kit, which will be used for placing the IV if we were to place it before going into the operating room. We offer food flavors for the mask, so that when your child is going to sleep with the mask, instead of having to smell the pungent odor of the gas, they will actually be smelling the food flavor. And that totally changes in how they are receptive to, getting the mask on their face. Imagine a stranger putting a mask on your child's face. The first reaction is going to be to either fight or cry or take the mask off. But when they have been gradually introduced to the mask, they've had the chance to decorate that mask with stickers or put food flavors and smell the flavors. It totally changes their outlook on what to expect, and they are more receptive and they are more willing to go through this without resistance. Next slide, please. So types of anesthesia, I would say for most pediatric patients, inhalation induction, which is mask induction or gas induction, is the way to go. Now, general anesthesia usually is either inhalation induction or intravenous induction. But for pediatric patients, in general, inhalation induction is offered for children below 10 years of age, or cutoff weight is 40 kilos. If the child is older than 10 years, or if their weight is greater than 40 kilos, most of the pediatric anesthesiologists will have a conversation with the parent or the child to have an intravenous line placed first and have an intravenous induction. But if a child has sensory issues, or if the child has had, autistic-like symptoms, no anesthesiologist will force your child to go through an intravenous induction. They will cater to their needs and they will proceed with an inhalation induction. The agents we use for inhalation induction are usually nitrous oxide, which is a laughing gas, and sevoflurane. And a combination of this will assist your child to go to sleep within 30 seconds to a minute. And following this will come the phase where we decide whether we want to proceed with intravenous anesthetic for the rest of the procedure, or we want to continue with inhalation or the volatile agents or the gases for the rest of the procedure. Both these techniques are safe for patients with HAD syndrome. Both these techniques are safe for patients with hypotonia, developmental delay, ataxia. There has been no one is better than the other, or one is worse than the other. They both are considered safe, and if your anesthesiologists are offering you either of these, you should feel rest assured that they know what they're doing. Next slide, please. So now maintenance of anesthesia depends on the type of procedure, the length of procedure, the invasiveness of the procedure. Though the induction, that means the initiation of anesthesia, usually for pediatric patients, will take place with a mask, following which is a period where we have to decide whether we will be able to finish the entire procedure with just that mask and the gas. So depending on the length of the procedure or the invasiveness means how painful this is going to be or stimulating this is going to be when the surgeon is doing it, the anesthesiologist will continue the rest of the anesthesia either with a gas or intravenous, and hence they will put an IV line for the patient after the child is asleep, and then have a continuous flow of an intravenous medication through the IV to keep them sedated, monitored, and safe. If the surgeon says the procedure is really short, it'll take only 15 minutes, we might complete the full anesthetic with just the gas. If it is longer than 15 minutes, we feel it is always safe that we put an intravenous line. So we can give other medications like anti-nausea medication, pain medicine, or a medication that will keep them comfortable and sleepy afterwards. The one thing that all anesthesiologists will definitely do and is highly recommended is avoid neuromuscular blocking agents, which cause muscle paralysis. And this is very important that I share this with you, because if a child has hypotonia or ataxia, which is like imbalance or lack of muscle tone, we want them to have full recovery of their muscle tone after the procedure. And if for some reason the anesthesiologist had to give a relaxing agent to your child because the surgeon requested a full optimized surgical condition for them, this muscle relaxant has to be completely reversed with reversal agents. And we are fortunate now that, at least in most of the countries, we have an agent called Sugamadex, which causes immediate reversal of muscle paralysis when given. And hence, the child can be back to their baseline muscle tone as soon as they wake up. So, though it was a standard or a blanket statement for anesthesiologists before that do not use any muscle relaxants because a child with hypotonia may have more weakness or more difficulty coming back to the baseline. Thanks to again research and innovation, we have been able to discover this drug which actually reverses the effects of muscle paralysis immediately. Regardless of that, anesthesiologists are very vigilant and they avoid using any muscle paralysis, and they use lesser doses of all the agents that have to be used, because we know that, one, that we don't need them, and second, we want to bring them to their baseline status as soon as the procedure is done. Next slide. So intraoperatively, again, once the psychological preparation of the parent is done, the anesthesia plan is discussed with the parent in the preoperative area. The child and the parent are accompanied by a child life specialist into the operating room in most of the institutions. And this is called parent presence for induction. This was, I would proudly say that Mass Eye was one of the first few institutions in the country to spearhead this initiative. And this really, I think, empowers a parent to be present for their child, advocate for their child, and also for the child to have the comfort of their parent to be with them when they're going to sleep. Like I mentioned, short procedures might be completed just with a mass technique, but for longer and invasive procedures, we put an IV after the child is asleep and we access their airway. Now, again, children with hypotonia or any other syndrome can have a difficult airway or an unknown airway because they've never been to the operating room. The airway has never been accessed before. So we keep a barrage of equipment, supplies, and gadgets around us, because we want to make sure we have everything available when we are inducing anesthesia in your child. So to secure an airway in your child, we will have supplies like an LMA, an endotracheal tube, a glide scope, a CMAC, a fiber optic bronchoscope, all this to make sure that we are not scrambling or we are not unprepared, because we don't know what to expect in your child once they are just about to sleep with the mask. We want to be thoroughly prepared that we have, all the gadgets ready for them. Like I mentioned, an intravenous access might be difficult sometimes, so we keep additional resources ready. We have vein finders, we have ultrasound machines, we have intraosseous kits in children with extremely difficult IVs. We monitor the body temperature of your child. We have blankets called as bear huggers, which provide forced air and they keep your child warm. We also warm the operating rooms before bringing your child in so that they don't lose their body temperature soon after induction of anesthesia. Next slide. Now, post-operative recovery is again a very big component of the perioperative journey of your child. Patients with any syndrome or even just autism, most of the hospitals will have quiet rooms for their recovery because we are sensitive to their sensory needs. We want to be present to monitor their respiratory status. We want to make sure they're oxygenating well, they're ventilating well. And hence, I mentioned to you that we like to keep gadgets which can provide CPAP or high flow oxygen, or keep some supplies around the bedside, even in the recovery room, that in case they woke up with having problems breathing, we would be able to intervene and do the needful even by the bedside. Since I've learned recently that HAD syndrome children have high pain tolerance, we in general in pediatric anesthesia avoid opioids because of this very strong side effect profile for their respiratory depression effects. And most of the children usually get Tylenol for pain. And if HAD syndrome patients have high tolerance to pain, then I would highly recommend that you talk to your surgeon and your anesthesiologist to avoid opioids and to see how your child is doing in the recovery room. And if they do exhibit signs and symptoms of pain, then to introduce opioids in very small and in incremental doses, and not to give the normal dose of an opioid right up front. Emergence agitation is usually seen when only the gas has been used for the entire anesthesia. And I would say that HAD syndrome patients, they would have less frequent agitation issues in the recovery room based on what I've read about their, I would say, their emotions or their fear of needles, or the cry that I have read in the stories, that they don't cry as much when they are in pain. I feel that they will very less frequently exhibit agitation on wake up. But if it does happen, we have agents that can take care of it. And again, give these agents in very small doses, in incremental doses, rather than giving the full dose up front. Nausea and vomiting, I had already addressed that most of these kids will have some gastrointestinal problems. They might have, sphincteric problems, and so they might be usually probably presenting with motion sickness or spitting up after a big meal or a big feed. So if you follow the NPO guidelines, the fasting guidelines, and if we give them what we usually do, a couple doses of prophylactic anti-nausea medications, which is ondansetron, also known as Zofran, or if we give them a steroid dose, that would totally be a prophylactic dose to avoid nausea and vomiting. But if they do exhibit symptoms of nausea and vomiting in the post-operative period, the anesthesiologist and the nurses are well aware of how to treat it and make sure that your child is safe and comfortable so that they can tolerate feeds after that. And again, the most important piece, right from the time you enter the hospital to the time you leave, we constantly revisit, the information that you have provided us to format the final plan of whether your child is going to get admitted and be monitored overnight or is safe to be discharged home, because we do not want your patient or your child to go home and to be in a situation where you feel uncomfortable taking care of your child and you have to rush back to the hospital. So again, there is a constant collaboration, constant conversation, open dialogue going on between the nurses, the parents, the anesthesiologist, and the surgeons. And goal is to keep your child safe and provide the best quality care. I'm noticing that there have been some questions posted, and I have not looked at the chat, but I will get to it as soon as I finish my presentation. I think this might be one of the last slides. So next slide, please. Okay, so yeah, these were some of the references that I have listed. You can read any one of these. They should be available online. anesthesia for a hypotonic child or for a floppy child, and any morbidity or mortality related to usually children with mitochondrial defects. Fortunately or unfortunately, there isn't much literature on HAD syndrome yet, but I'm telling you, most of the symptoms that have been shared by either parents or by the researchers in this field have been similar to what we have encountered in other syndromes. So though we don't like surprises, but in case you do end up showing up, to a pediatric institution or a children's hospital and your child has had syndrome, I'm sure you will get the best care, because they would have taken care of a child with a different syndrome but with similar symptoms or features, and they will do whatever it takes to keep your child safe. Next slide. Yeah, thank you so much for inviting me, and I hope I have at least given you an overview of your journey when your child is booked for for a surgical procedure. But again, I will share my information. If there is any question which I cannot answer today, I will provide answers to you via email, or I will be in touch with you even via a phone call if there is a need. We are all here to make sure that we keep your child safe and really provide the best care. So thank you very much. And now I'll be open to questions. I'm opening the chat right now.
Thank you, Dr. Sahani. Yes, we have several questions in the chat.
Oh my gosh. Okay.
And I know that we have had a lot of people here and around just kind of saying, yes, this is resonating. And obviously some of us have had some run-ins with, unfortunate anesthesia episodes. And so thank you for speaking. It is quite comforting for our community to have an expert such as yourself kind of break down what's needed in order to keep our kids safe. The first question that came through the chat, and I'll run the mic around the room as well, is in the use of nitrous oxide, is the use of nitrous oxide safe for minor care needed testing, etc., for a child who has had multiple anesthesia complications, including complex laryngospasms, and on a separate failed emergence requiring 3 times the Narcom and reversal meds?
Perfect. A very great question. So nitrous oxide is not necessary. It is a sevoflurane gas, which is actually the anesthetic, which allows your child to go to sleep. Nitrous oxide is safely used in a child who has no respiratory issues going on the day of the presentation for the procedure. It increases or fastens the delivery of the sevoflurane. And because it is a laughing gas, a lot of anesthesiologists will use it only for the first few breaths so that your child is not smelling the pungent odor of sevoflurane as soon as a mask goes on their face. So they turn on nitrous oxide just for the first 5 or 6 breaths. So when they breathe in the nitrous oxide, it being 200 times more solvent in the blood compared even to oxygen, it reaches the brain very quickly, and it gives them a sense of euphoria, or and hence they laugh or they smile. And right after that, when the sevoflurane gas is turned on, the nitrous oxide is actually turned off, and now the child doesn't really care much which gas they're breathing, because this nitrous oxide has totally changed their network in their brain. They are in a different state of mind. They are not feeling what the sevoflurane is doing to them, and their induction is smoother, faster, and I would say more pleasant. But nitrous oxide is not at all necessary. If the child is very young, is a neonate, is a newborn, is a young child with respiratory symptoms, most of the anesthesiologists will never turn nitrous oxide on. And if the parent accompanying the child is also pregnant, is in their first trimester, they will not turn nitrous oxide on, because it can have some effects on the DNA duplication, replication, and all that. So this is just an adjuvant, an additive to the sevoflurane effect. It improves or it fastens the speed of anesthesia, and hence that initial induction where you want your child to go to sleep fast and not remember much is where the nitrous oxide is helpful. I would also reassure you that very soon nitrous oxide might even get completely eliminated because it is a greenhouse gas, and eventually everybody is being pushed to use avoid gases which are greenhouse gases. The other gases were desflurane and isoflurane, and just recently desflurane gas has been taken away from most of the hospitals in the US. So nitrous oxide is not unsafe. It is unsafe. It is used in patients with laryngospasm or respiratory failure only because your child might not have the reserve in their lungs to have a mixture which has not only oxygen but a different gas which is more solvent than oxygen. So if your child has any of those respiratory symptoms, the anesthesiologist will not use nitrous oxide. I hope I answered that question.
Wow, thank you so much. Yeah, very, very helpful.
Yeah.
Another question that came is, are there any other medications or anesthesia practices you would recommend to avoid for our children with the other than what you just stated?
I would say most important one is, muscle relaxants. If the surgical procedure is very invasive, like it's an abdominal procedure or the spine procedure, where the surgeon really needs all the muscles to be relaxed more than they are at baseline, the anesthesiologist might have to use a muscle relaxant. And there are various classes of muscle relaxants too, right from short acting to very long acting. And they will base their choice on depending on the type of the procedure or the length of the procedure. Each muscle relaxant has a reversal agent, but like I mentioned, Sugamadex is a recent most drug, which is like a magic drug for us now. And if we've had to use muscle relaxant for a procedure in a patient with hypotonia or any other neurological problems, we use that agent to reverse the effects of that muscle relaxant completely before we even attempt to wake up the patient, so that we have eliminated that as being the cause of any, muscle tone issues or any hypotonia afterwards. So we are able to reverse it completely now. And the other agents that I would avoid, or medications I would advise, even the surgeons from prescribing to the patients after procedures is opioids or narcotics, because they depress the respiratory drive in the brain. So if a child is already developmentally delayed, or if they have other neurological issues going on, autism and things like that, or they have, respiratory symptoms of sleep apnea or laryngospasm or laryngomalacia, where they're already struggling with their breathing or maintaining the oxygen, then opioids depress the respiratory drive. They make your child breathe less. They make your child breathe smaller breaths. They make your child stop breathing for shorter periods of time, what we call as apnea. So those apneic episodes become more frequent if your child is put on opioids. So as anesthesiologists, if we have to use opioids, we use the ultra short acting opioids or the short acting opioids for the part of the surgical procedure during the surgery. But for the post-operative period, the longer acting opioids, which are morphine or Dilaudid, which is hydromorphone, if they do have to be given because the procedure was so painful, things like that, then we do like quarter dose of the opioid, or even completely avoid giving it. And then we wait for the child to wake up in the recovery room, see their response, see whether they really are experiencing pain. And if children with HAD syndrome already have a high pain tolerance, then probably they may not need it at all. So why give them something preemptively and then have to reverse it with Narcan? Rather, wait for them to wake up and then assess their pain, use the different pain scales that the nursing team will, use in the recovery room, and then do smaller doses and see the effect versus treat it upfront and then, have to reverse it.
Thank you. Kelly Maston wrote, anesthesia greatly improved anesthesia greatly improved for my child when I refused the use of Versed. Does that admission make sense to you in the story of HADS and anesthesia?
So midazolam or Versed is an anxiolytic. It basically in children who present with anxiety, it is a very commonly prescribed or medication that is administered in the preoperative setting. And sometimes it can have a paradoxical effect. And we don't know which child will have that paradoxical effect. 90% of the children will actually become very calm. They'll become a little sleepy. They'll become very relaxed. They might even smile. They might even laugh. They might become more open to, putting the mask on their face, or even be open to having an IV placed in an awake situation. Very rarely, like I said, 5 to 10% of patients might have that paradoxical reaction where they will become more nervous, more agitated, more withdrawn. And since we don't know which child will exhibit that kind of reaction, if your child has had one such encounter, you should definitely make a note of it so that when you go to, for a different procedure at a different institution or the same place, make sure you mention that to your anesthesiologist so that they don't administer it. I would not make it a blanket statement that do not offer, Versed to patients with HAD syndrome. It's a very useful drug. It is when it is used in the right situations, right scenarios, it is very, I think very pleasing and makes the entire encounter very different for the child and the parent, that the fear, the anxiety is completely eliminated.
All right. And then to follow up on, thank you for that answer. To follow up on the original question that we had about nitrous, there's a clarifying question which changes it quite differently. If they were basically saying that they are saying they would like to try nitrous for the next testing procedure instead of any other anesthesia because of her history. Would you recommend, I know you said nitrous has the effects that it does, but if there was no anesthesia that you're traditionally using, would that be a treatment plan that you would recommend? Basically swapping them out?
So one minute, I'm just reading the question that they are stating they would like to try nitrous for our next testing procedure. Depends on what is the testing procedure, and is it some dental procedure which is really quick where they just want to, so like there are many diagnostic procedures where children with HADS syndrome might have to undergo, and like I said, some procedures are really not painful, they are really quick, and especially the dental ones, and they are performed only with nitrous. And till date, I have not seen any complication with nitrous. The literature and the current, I would say, the current recommendations from the American Society of Anesthesiology is just based on the greenhouse gases elimination and all that, is asking us to minimize our use of nitrous. But that is for a prolonged period of time. If it is to be given for a short period, like I said, I would actually use nitrous oxide for induction of anesthesia in a child without any respiratory problems, because it makes their experience so much better. It increases the speed of induction. It prevents them from having that negative memory of the whole process and the whole procedure, that it is worthwhile to keep it on, and not eliminate it completely. So if their anesthesiologist or their institution is recommending use of nitrous for a very quick testing procedure, I'm not against it. I think it is worthwhile. The only other side effect of nitrous, if used again for a prolonged period of time, is nausea and vomiting. But if it is used for a diagnostic quick procedure, and they want to avoid using sevoflurane so that the hypotonia doesn't become worse, because then they just have to be in the recovery room for a long period of time, or they want to avoid putting an IV, then a quick procedure with nitrous is totally safe. I'm reading that question on sleep apnea. That is very, very important. I would like to talk to you about this. So, any child with hypotonia, already when they go to sleep, their muscles are going to relax around the airway and cause some obstruction of their airway in their sleep. And that might result in them having symptoms of snoring or changing their position in their sleep, or I would say, or developing new symptoms like feeling tired during the day, taking more naps, and things like that. All this is suggestive of obstructive sleep apnea. But children with HAD syndrome, because there is a delay in the neurodevelopment, they do have central sleep apnea, and hence the surgeons, before they perform any procedures, will get a sleep study done so that they know how much component of the sleep apnea can be, I think, blamed upon on the central component of it and how much of it is obstructive. If they think that the obstructive component is significant and the child has large tonsils or adenoids, it is really worthwhile to get the tonsils and adenoids removed, because you want to take away that obstructive component from your child so that the airway is more open. So even when they do have the central component where their muscles are relaxing or their respiratory center is getting depressed in their sleep, at least the airway is not obstructing them from exchanging oxygen and carbon dioxide. So do not hesitate to get this procedure done. And if the sleep study demonstrates that their sleep apnea is anywhere from moderate to severe, and they are recommending that your child stay in the intensive care, please go for it. It is the safest thing you can expect in terms of, monitoring and safety of your child. In my institution, we would always admit our patients with severe sleep apnea in the ICU. Fortunately, now over a period of 10 years, and with COVID taking up all our ICU beds, in the last 4 years, we had to revisit our data. And because of the kind of protocols we have developed around how we treat our children with sleep apnea, we realized that none of our patients who were going to the ICU actually had any complications of sleep apnea recovering there. So we have reduced the number of patients going to the ICU, and they now stay in-house only on the floor, because we minimize the use of opioids, we minimize use of muscle paralysis, we minimize, or rather we give Tylenol only for pain, and we give them dexmedetomidine, which is a very, very safe drug, which is an anxiolytic. It has pain-reducing properties. It does not affect the respiratory drive. So when you do all these measures, even patients with severe sleep apnea do not need ICU care. But if your institution or where your child is going to have their tonsil procedure done, if they're not following a protocol which has all this in place, then sending them to the ICU for recovery is the best thing you should expect, and you should go for it.
I have a question. So how concerned are you about, I'd read about some of the concerns around repeated exposure to anesthesia as when a child is young, and that being kind of leading to maybe neurological or deficits later, and especially for kids with HADS, who already have a neurodevelopmental condition. What is like the latest research and thinking on that? Like how, obviously you wouldn't do anesthesia unless you really needed. So I imagine you only do it when the benefits outweigh the cons, but how much of a concern it is, like what do we know really about what kind of impact it has later in life? Like for my child, we had some testing procedures when she was less than a year. And now I just I can't help sometimes wonder, I was like, did that contribute to some of her being slower to process things or not?
So not only did you ask me a question, but you actually answered most of it. So there is a lot of controversy in what our anesthetic agents do to a child, when it is a long procedure and the anesthesia has been given for a prolonged period of time. Again, you already answered my question. We would rather do very short procedures and very infrequent procedures in any child below 2 years of age, and we would weigh the risk and benefits depending on, why they need it, what they need, when they need it. So there are studies which have been done on twins and on siblings, one with, full normal brain development, children with, probably some delayed development. And they have found no difference in twins. They found no difference between siblings. They have not seen any regression in their development following anesthesia. But it is such a multifactorial thing that is happening, simultaneously, that it is impossible to blame anesthesia for what is going on. We have seen delirium in patients, post-operatively, but that also resolves within a couple hours. And in fact, I've heard from some parents that, they had a lot of pre-op anxiety, pre-op behavior problems. Sometimes they received anesthesia and actually all that improved. So maybe, our drugs went in and changed some networking in the brain. I've heard only positive things, and I keep asking my colleagues, and I keep reading literature. There isn't any new data. What has been there from the studies that were presented like probably 5 years ago. Nobody's doing any new research because nothing concrete came out of these studies. So we also prefer not to anesthetize your child unless it is absolutely necessary. We prefer to do short diagnostic procedures in the early years of life, unless a elective long procedure, a corrective procedure is going to improve the quality of your life, improve the neurodevelopment of your child. Like I would say, if your child has to undergo a tonsillectomy before 2 years of age because they have severe sleep apnea, I would say, please go for it, even if the anesthesia is going to be for an hour, because right now your child neurodevelopment is going to be affected because of the sleep apnea more than because of that 1 hour of anesthesia. If your child is having failure to thrive and you need a G tube, of course, place a G tube in, because if you're not going to provide the nutrition that your child needs, that is going to affect the long-term growth and neurodevelopment of your child versus that 30 minutes or 1 hour of anesthesia to place the G tube. So it is really about, weighing the risk of the procedure and its benefits and keeping anesthesia in the back end, but treating it as a friend rather than as an enemy. And that is what I tell my parents. Think of us and anesthesia as your friends, because we are here to treat you, to give your child what they really need at that time. And the effects of this are going to be short-lived. And especially when we know your child is presenting with developmental delay or hypotonia, we are already cutting down on the doses of, the medications, the even the volatile agents. We go down on lower concentrations. So we are constantly thinking about what is right for your child. We are very vigilant. We are very cognizant of all the effects that, each medication or each agent has, how they metabolize, how they get excreted. And so we don't want any long-term effects on your child. So I would say that if you're going to a children's hospital, you're going to a tertiary center, your child is being cared for a pediatric anesthesiologist, you should be rest assured that you are getting the right information and the right treatment.
And nitrous oxide is not linked to any long-term issues, right?
No,
the way the
not
other.
at all.
Okay.
No, unless it is the mom is pregnant and she hasn't informed us. She's in the first trimester. Her older sibling, her older child is having anesthesia. She's present by the child, and she's getting she's smelling some nitrous, which is very rare, which is very, very rare. But if she is undergoing anesthesia herself and she's unaware that she's in a first trimester of pregnancy, and the anesthesiologist has used nitrous for the entire length of whichever procedure she's having, then we've heard that, there is literature to prove that it affects the replication or duplication of the enzymes that are required for building of the DNA blocks, and there might be some issues, but that is only in a pregnant woman in the first trimester, and if she's having nitrous oxide for a very lengthy procedure, but not in your child.
Thanks.
Thank you so much for staying late, answering all of our questions.
No,
We really
it is my
appreciate
pleasure. Yeah.
Thank you so much.